Hello, and welcome to the Health GoLIVE Webinar series. Today's episode is brought to you by your friends at Advisory Board. We would like to remind you that the chat feature is available, so feel free to send in your questions and comments throughout the discussion. We would love to hear from you. And with that, I will turn it over to Rachel Woods, Vice President, National Spokesperson and host, Radio Advisory Podcast at Advisory Board.
Good afternoon, everyone. We are going to go ahead and get started. A few folks might continue to trickle in, but I never like to punish the punctual, so we're gonna go for it. My name is Rachel Woods. I am Vice President and National Spokesperson for Advisory Board. I hope that my voice is familiar to you all if my face is not. And that is because I am the host of Advisory Board's premier podcast, Radio Advisory. If you're not familiar with the podcast, go ahead and use this QR code now. I want this in your inbox every Tuesday. We're on all podcast platforms. If you like keeping up to date with the latest healthcare information, if you like real talk about how healthcare leaders should navigate and frankly grapple with some of the most complex challenges of the moment, of which there are many, this is your source of that information. Episodes drop every Tuesday, so expect a new episode tomorrow. But let's focus on why we are here today. This is Advisory Board's annual State of the Industry presentation. This is our perspective on what's happening in the market today, where industry dynamics are headed next, and how leaders across all sectors are setting their strategy for the future. Now, those of you who are familiar with Advisory Board know that we launch a new version of this research every year. In fact, this version that I am showing you all today is just a couple of weeks old, maybe 2 months old at this point. But what you might not know, and what I'm happy to reveal to all of you, is that this is actually a constantly evolving body of work. We are always tweaking, sometimes changing significantly what we're saying about the state of healthcare right now, because we all know that there is no such thing as a slow news cycle in healthcare, hence why we decided to also launch a podcast. In fact, if I'm honest, the work that I'm going to show with you today is different than the version of the state of healthcare that I shared just 2 weeks ago to a different group of health leaders. So what I want to do today is I want to take a zoomed out look at some of the trends that, frankly, I think a lot of us have been paying attention to for several years now. The difference is we've been seeing some of those trends unfold slowly. Not anymore. We have all been watching as some paradigm shifts have been evolving. I'm talking about in delivery infrastructure. I'm talking about in the rise of vertical ecosystems, changing care team roles, changing treatment economics, changing innovations, changing drugs. Those things aren't necessarily new. However, unique developments today mean that they are hitting acceleration points. And there is no better example of this than the rise of artificial intelligence and how, frankly, it is already changing how we think about the care team. So whether you are a provider, a health plan, a life sciences company, a purchaser, an enabler, anyone else, I want to help you prepare for the future of artificial intelligence. I want to help you make better decisions in the face of, frankly, all of the other changes that are happening simultaneously in healthcare. Now, before we dive into where the industry is going, I do want to take a moment and reflect on where we've been, particularly as we emerge from the shared catastrophe that is the COVID-19 pandemic. Now, from that chaos, and I would describe it as chaos, we have entered into a new moment, and that moment is just more instability, right? We're in this phase where, if I'm honest, I think a lot of health leaders feel antsy. I often start more interactive presentations by asking health leaders to describe the state of the healthcare industry in one word. And I will tell you, the words that I hear often are things like unstable, chaotic, fragile, and I'm not sure that those sentiments are wrong. I often start these discussions about healthcare business by talking about policy changes, talking about purchaser movements, and I am going to get there. But for this presentation, I wanted to do something different. I want to start by acknowledging the heart of our business, or frankly, what should be the heart of our business, which is our patients. I want you to look at some of the numbers on this slide. Patients are worse off emerging from the COVID-19 pandemic in several ways. We are seeing more patients delaying or skipping necessary care, delaying and skipping preventative care because it's just too expensive, right? We're seeing rising behavioral health needs. We're seeing decreases in vaccinations. This is my moment to remind you that flu season is upon us. Go get vaccinated. We're seeing more people miss their diagnostic tests. Some of this is bad and staying bad, and some of this is just getting worse. One particularly painful one is at the bottom of this slide. We are also seeing an increase in workplace violence. And I think that speaks to the fact that the patients are just not okay. They're not okay medically, financially, socially, and they're taking it out on us. They're taking it out on the frontline workers when both patients and frankly staff are at their most vulnerable. There's all this frustration with healthcare for sure. And we're going to talk more about that. But I also just feel like there's this frustration with life, right? And so this is the picture of the patient that all of us, no matter where we sit in healthcare, intend to serve. And that's as we're coming out of the pandemic era. And I want to be clear here, the patients are not okay because the healthcare industry is not okay. We are in a very tough moment. If you look at the data on the left-hand side of the slide, you will see that there has been an increase in adverse events. There's been an increase in maternal mortality. Quality and safety are suffering. In fact, this is not a laughing matter, but it might put a little bit of a smile on your face. Nearly every quality and safety measure is down in 2022. In fact, the only quality and safety measure that got better is, don't worry, you're still less likely to have a surgical instrument left inside of you. Maybe that's a bigger reflection on the supply chain issue. I don't know. Things are getting worse, and our patients know this. 73% of adults believe that the healthcare system is not meeting their needs in some way. I'm going to say that number again. 73% of adults believe that the healthcare system is not meeting their needs in some way. That is a huge number, and that is unacceptable. At the same time that we have this declining quality outlook, we've got looming spending pressures. Take a look at the data on the right-hand side now. Now, this is the annual growth in healthcare expenditures per capita. We've got this big spike in the middle around the COVID era, right? We all know that came from federal support funding. I want you to ignore that. I want you to look at what's to the right of that big spike. We are well within the spending growth that was happening the last time we all had a big debate about healthcare costs, right? Remember way back to 2019, a whole lifetime ago, a whole planetary crisis ago, when we were having a debate over Medicare for all. We are seeing the very same spending numbers again. The frustration hasn't gone away, even as we've emerged from the COVID era. And the economic climate that we're operating in is just getting tougher. I want to take a look at some of the numbers here. Look, businesses are struggling. They are struggling with high operating costs, particularly in labor, high borrowing costs, a volatile stock market, the challenging macroeconomic environment, coupled with continued interest rate hikes, are tightening investment capital. And that economic reality means that the number of deals is actually down. Right? It's down at a time where things like biopharma, medical devices, digital health, artificial intelligence, right? What we're going to talk about, they're more strategically important than ever before, even as the number of deals is down. And this tough climate, this tough economic climate is going to have ripple effects across the entire industry, which you can see I've outlined at the bottom of the slide here. First, significant investment income losses, even for the biggest health systems, that's important. Right? Second, capital and labor costs means that our traditional growth mechanisms all squeezed, right? And organizations are being a lot more selective about what kind of growth opportunities they actually pursue. And then lastly, new ventures are just trying to stay alive. In fact, I would argue that they're a bit desperate to stay alive, which we all know doesn't necessarily mean that they are going to make prudent moves. We're in this moment of instability. And everyone in healthcare is trying to figure out where we're going to land. What will our new equilibrium actually look like? I want to take some time to walk you through the data points on this slide. And they're in a particular order on purpose. On the top, there are 2 data points that highlight unusual inconsistencies. These are things that I don't think are likely to last, right? So on the left, a labor market that is booming despite cost cutting in other areas, right? Several million jobs added in the last year. That's a temporary inconsistency. I do not believe that that is going to last forever. On the right, I can't believe I'm still saying this in September of 2023, but we are still trying to understand what the volume trends will be coming out of COVID. A few months ago, you may have noticed that some of the biggest managed care companies lost over 50 billion in a day in market cap, when United just happened to note that they're seeing more surgeries come back than they expected. That's what I mean when I say antsy. Now, is this a permanent increase, or is this kind of a one-time post-pandemic surge? I'm not sure. The bottom numbers, these represent data points that represent major permanent changes. They might be gradual changes, but they are permanent, and we will have to grapple with them. On the left, artificial intelligence, right? We know that the cat is out of the bag here. 1.5 billion people using AI chatbots around the world. There is no going back to a pre-generative AI world. One of the former head of AI for Microsoft, who's actually been on the podcast several times, is going to come back on later this month. He likes to say, trying to go back to a pre-AI world, pre-generative AI world, is like saying, let's temporarily suspend gravity. That's how permanent that change will be. Right? Even as we have no idea what our future state will look like. We're not sure, where will the governance, where will the regulation actually end up? We're having conversations in Washington, right, where I live, just last week about that very question. We know change is coming, and that is a big part of our conversation today, but it's hard to predict how much change. Now, on the bottom right, we know that there is increasing scrutiny of the healthcare industry and of the pharma industry in particular. Medicare is expecting to save $100 billion from drug price negotiations over the next 10 years. Those negotiations are in their very early stages. We know that through the Inflation Reduction Act, the first 10 drugs have been named as of just a couple of weeks ago, but we don't yet know what, frankly, the prices are going to be, or what the outcomes will be, or how those outcomes will affect any other part of the industry, from prices to new drugs to insurance premiums. Permanent change. And we have to determine, we have to navigate what is the ultimate outcome that's going to come from that. We know that things are changing. We don't know where we're going to end up. And the best way that I can sum up this feeling of instability, of inconsistency, this feeling of needing to make a knee-jerk reaction, of feeling antsy, is this quote on the right-hand side of the slide. This is a quote from a leader on the front lines. And this is in Q2 of this year, a CEO of a large health system who said, "This is the first time in my 30-year career when all of my beds are full, and yet I have no margin." And I tell you that to say that this is a time where many of the foundational truths about our business, frankly, the truths that we take for granted, are no longer holding up. Things feel like they don't make sense. Things are inconsistent, but they can't stay this way forever. So my takeaway for you is that if I look at the industry right now, in this moment, in September of 2023, we're in a moment of instability. We've emerged from this shared catastrophe that was COVID, coming out with a very, very fragile foundation. The healthcare industry is underperforming on basically all counts. We're seeing poor patient health, declines in clinical quality, and increases in overall spending. So it's no wonder that there is mounting scrutiny on the current business practices and current business structures in healthcare. People are unhappy with the outcomes, and regulators see this moment of instability as an opportunity, right? Regulators see this moment and they say, I could make some moves, some potentially dramatic moves to tighten business models and spending. Here's what I'm saying. I'm saying that the overall environment that I just described, the environment of underperformance, is ripe for purchasers to turn the screws. And this is essential context for the state of the industry going into the next year. Before we can talk about a specific innovation, a specific disruptor, before we can talk about AI, I am going to take a few slides to show you just how purchasers and policymakers are getting more aggressive and more prescriptive, because that is essential to understanding the state of healthcare, and it's essential to understanding the decisions that you will need to make going into 2024, right? Now, as I continue through this conversation, I would love to get questions, comments from you. Please make sure that you are using the chat function. I've got that here, and I'm happy to answer questions and even address comments as I go. With that, we understand the snapshot of the industry. We understand that purchasers and policymakers are looking at us and saying, maybe I can turn the screws even more. Let's look at what that means. And I'm going to do this by looking at a couple of different purchasers, right? And I want to start by looking at shifts impacting the ways that patients get coverage. The solid bars on this slide show the change in enrollment by coverage segment from just before the pandemic to the end of 2022. We know that we saw drops in employer-sponsored insurance. We saw drops in traditional Medicare, right? MA enrollment increased. Obviously, we saw a massive rise in Medicaid enrollment during the PHE because the federal government increased support and importantly, made it impossible to actually disenroll patients from Medicaid during that time. But those were temporary policies and they have largely winded down and many individuals are no longer able to stay on Medicaid. The question that I get is, where will all the coverage shifts actually shake out when this is all said and done? And the answer to that is, while of course we expect to see this whiplash backwards in Medicaid enrollment, we are still going to have a lot more public coverage after the redeterminations are done. I'm going to say that again. The media is focused a lot on this whiplash of all these people that are losing their Medicaid enrollment. And importantly, a lot of those folks are going to end up with employer-sponsored insurance. That's the data on the bottom right-hand side. But in the end, we're going to actually have more enrollment in Medicaid and in the individual marketplace than we had before. And my prediction is we are going to continue to see a shift towards public coverage when all things settle out. But I know the question that's on all your minds. What about all of those ineligible Medicaid enrollees, right? That's what we need to talk about. And again, I know that many of you have seen headlines about millions losing their Medicaid eligibility. This chart breaks that down. This chart shows where things stand across several states that have reviewed eligibility for most of their beneficiaries. Now, the black bars show the number of enrollees who have lost coverage. These are the ones who are definitively not eligible. The red bars show that many beneficiaries are losing their Medicaid coverage because they're actually just unable to complete the paperwork, right? Or maybe the state couldn't figure out whether they were eligible or not. And so by default, they're actually losing their eligibility. Gray bars show the number of enrollees who are renewed. It is important to note that some of those disenrolled patients could be eligible for Medicaid still, but they're losing coverage regardless. They are losing coverage because of paperwork burdens, right? And as you can see on this chart, how this actually plays out is very different when I look at different states. Some states have spent a lot of money and spent a lot of effort to try to streamline this process. They've invested in navigators, they've invested in marketing. Others haven't done very much at all, right? Which is why we see such discrepancies. So as states are trying to review their eligibility, it's become increasingly clear that this is a difficult process. The administrative burden here, the paperwork, the logistics, this is hard. And so far, the disenrollment rate is shaking out to be twice as big as originally predicted in terms of people who are getting kicked off, right? Now that's going to slow down, right? Because many states targeted early redeterminations on the ones that they thought would be most likely to be ineligible, that they were most likely to get correct in their ineligibility. And then of course, CMS is encouraging states to take time and resources to try to get this right. What I'm saying is there's still going to be whiplash. It's just different than what I think we predicted 6 months ago. And the people who are going to feel that the most is patients, is people, right? During this period, if you're a patient that's trying to switch coverage or get their eligibility renewed, or maybe you lose coverage and then gain it back either through your employer or perhaps through Medicaid after all, that is going to impact your ability to access and adhere to your care plan. I'm talking about your medication regimens. I'm talking about care continuity with physicians. It is going to have an impact on patient care. Now, states have their hands full with Medicaid, and states and health plans also have their hands full with Medicare Advantage, which I'll probably refer to as MA throughout this conversation. And when I talk about MA, people describe it to me as a cash cow, right? We all know that MA is a very popular model. In fact, just this summer, we crested the 50% mark. More than 50% of eligible seniors are choosing MA over traditional Medicare. And that's just going to continue. It's projected to crest to 61% by 2031. And this is a good time to remind you that MA has bipartisan alignment. It has government funding going to plans and to providers, and that amounts to a big business opportunity. And so no wonder we have seen, even very recently, every major player, I'm talking UHC, Humana, CVS, Walmart, every major player has spent billions on infrastructure. They're investing in primary care. They're investing in home care. They're investing in risk adjustment assets, right? Because they know that their business can succeed if they succeed in Medicare Advantage. But with all of that MA funding coming from our trust fund, CMS and Congress are starting to take a closer look at the level of spending here. And they want to make sure that their payments are going to the right thing. So directionally, what we've seen is that CMS is actually trying to reduce costs by cutting things like reimbursement, making it more difficult to get bonuses, right? And despite the fact that CMS is making the business model harder, I still see players making big bets in MA because the margins are just good. Right? They're still high compared to other insurance segments, and 10,000 Americans age into Medicare every year. Those are numbers that are just so hard to ignore. But that doesn't mean that things aren't changing in the MA business model. Enrollment patterns are shifting, right? We've been seeing more and more beneficiaries choose PPO plans when they enroll, right? Now, from the health plan's perspective, not the patient's perspective, but the health plan's perspective, with a PPO, you just don't have as much control over the patient and the provider journey. So it's harder to win on the margin side. It's harder to navigate the patient towards the lowest cost option. Now, the incentives, again, the long-term kind of cost management, that's even harder when folks are changing their plans. It's not when they age into Medicare and they choose MA, they're going to stick to one plan. We still see tons of churn. I think it's like a quarter of beneficiaries switch plans in less than a year of joining. So that's a big shift that we're seeing. Another trend that I'm seeing is health plans actively pursuing special needs plans. You're going to hear this pronounced as SNP plans, SNP SNP plans, all right? These are models that are available through CMS because they have an opportunity for higher margins. There's a lot of focus there. These plans are different. They target specific populations, specific diseases, which means you need a lot of extra infrastructure, you need a lot of expertise in order to do well here. So if you're an MA plan and you're not able to do all of this, or you're not able to win in a particular segment like you can with a SNP plan, this is actually going to be a tougher environment, right? In this environment, we predict you're going to see a couple of core strategies to try to get a handle on patient management, right? Because that's the goal from the lens of the purchaser, which is what we're talking about here. I'm expecting more investment in specialist alignment. I'm expecting more acquisition of specialist groups, not just primary care. I'm expecting plans to explore strategies to shift beneficiaries from the PPO to the HMO, right? Where they can contain costs more, maximize revenue more, because they can guide, they can use kind of guardrails to guide members through that plan. And lastly, I just expect a continued trend towards asset consolidation, right? The money that is being spent to succeed in Medicare Advantage is something that we've seen grow and grow and grow over the last couple of years, and I don't see that winding down. Now, I want to talk about a purchaser that I'm not hearing enough about lately, and I want to make sure that you're prepared to speak to this. To speak to this. By the way, there's a question that came through the chat about why did it become more difficult to qualify for Medicaid? Remember, some states enacted new rules for Medicaid eligibility. I'm thinking about things like work requirements and so on. But even if the qualifications for Medicaid did not change, remember, the people changed. When COVID first hit, layoffs everywhere. Lots of people were losing their employer-sponsored insurance, turned to Medicaid. The rules under the public health emergency meant that states could not kick people off of Medicaid, even when they got new jobs. We were under the public health emergency for years, and a lot of folks who were still getting their benefits through Medicaid were eligible for other kinds of insurance, particularly employer-sponsored insurance. And that's a good example of folks that are, I want to use my words carefully, intended to be removed from eligibility from Medicaid because they have alternative coverage options. But it is correct to say that states have very different rules on who qualifies for Medicaid and who doesn't. Part of that is based on things like poverty. Part of that is based on some of the other requirements that they've put on. We talked about Medicaid. We talked about Medicare Advantage. Like I said, I want to talk about a purchaser that I don't hear enough about, and that is the employer. They are in a moment of activity, right? Healthcare costs have gone up enormously for them. Enormously, right? Employers have felt all of the effects of inflation getting baked into their premiums, and they're very, very concerned about the trajectory that they're on, right? And you can see a lot of that depicted on the left-hand side of the slide here. When they look at overall spending, when they look at hospital consolidation, all of the high-cost drugs coming down the pipeline, the rise in high-cost claims, they are extremely stressed about spending. And I will tell you, the ones who probably should be concerned are the smaller employers, right? They are very concerned about the unsustainable rise in costs, and they should be. I'll tell you that when we did this research, we actually spoke to a couple of brokers who shared with us that they had seen increase in costs 10%, 15% on average for small employers. One actually told me that they had seen cost increases as high as 30, 35% in some regions. That is truly unsustainable. Not, however, the first time that I have talked about employers when I've talked about the state of the healthcare industry. So your question to me, if it is not there already, should be, but Ray, are we actually going to see anybody do anything about this? Are we going to see more employers actually take action here? And there are a couple of reasons why I think it might be now, and they are on the right-hand side of the slide. First, employers have access to just more information. They've got more price benchmarking data through price transparency requirements in practice. They can get rates for like 90, 95% of the providers in their network. That means that comparison is possible, at least in the procedure space. Comparison is possible, which means that employers can scrutinize whether what they are paying for actually makes sense. And second is something that I want everyone on this line to know about, and it is the Consolidated Appropriations Act of 2021. The Consolidated Appropriations Act of 2021. It expanded employer fiduciary obligations, and they now have to better understand how they're actually managing their spending. Before, right, in the old times, employers were allowed to just trust their brokers, trust their health plans, that they were doing what they said they were doing. Now, employers have to prove that it's true. Employers have to say, we know that we are paying for reasonable amounts for healthcare. I know what you're thinking. How the heck do we define reasonable? I'll tell you, I don't have an answer yet, because we are going to see this unfold in the case law, right? There are already some cases playing out that we are paying attention to. And there's a little bit of dodgeball going on right now where no one wants to be the one who's responsible for attesting to what reasonableness means in terms of paying for healthcare. And once some of those cases settle, we're going to have a clearer definition of what that means and the responsibility for employers. We are going to see someone have to take some responsibility. And ultimately, that could mean that employees can band together, and I'm not kidding here, sue if they think that their benefits are not reasonable for what they need. This translates to a pretty scary time for employers because it's not clear what the impact will be and how much they will actually be on the hook. Like I said, we're going to see this play out in real time in the case law, but it's this kind of confluence of factors, right? It's the cost growth. It's more price transparency data. It's more expanded fiduciary obligations that make me believe that we are going to see more employers feeling pushed to take a more active role in reducing their healthcare spending. For those who are wondering, yes, I'm going to show a QR code at the end of this presentation so that you can receive the slide deck. So employers are going to take more of an active role. How are they going to do that? There's a lot of choices here, right? They can just offload their benefits. They can continue the status quo. They can manage navigation more actively, and they can scrutinize their partners. Now, what I'm saying by that is some are choosing to get out of this game altogether. They're saying, hey, I'm going to give you a fixed amount of money. Go to the exchanges, buy your own coverage. And others are wholly accepting that this is going to continue to eat more and more of their budget, and they're just going to absorb and offload the costs every year. The majority of employers are trying to do what we're calling active navigation management. They're trying to exercise a bit more influence over healthcare utilization of their employees, right? Prioritizing center of excellence programs, doing more hand-holding throughout a care episode, investing in more wraparound primary care, offering virtual first plans. All of these are examples of more active managed navigation. And by the way, if you're interested in hearing more about this, we actually, our podcast episode from last week is with Morgan Health, right? The subsidiary of JP Morgan Chase that is trying to figure out what is the right way to do this, to not just ideally reduce costs on behalf of the employer. That's the goal here, but also think about how can we improve or uphold outcomes for patients? How can we reduce costs for patients, right? Because that is often something that is lost in the discussion, right? Yes. No, there's a comment in the chat here. Since I didn't mention anything about the shift towards value-based care, it doesn't seem that that's happening anytime soon. It's important to remember that every single move that I have mentioned thus far from purchasers are all part of value-based care. I don't actually like to think about value-based care as a separate strategy or a separate entity. Take the one that I'm talking about right now, right? The things that employers are doing, the kinds of partners that they're looking for are to what? To reduce costs. What is the primary goal, or the double goal that's at the top of value-based care is to reduce costs and uphold quality. It is not something that is separate. It is baked into how all of these different purchasers are trying to reduce spend, right? Remember the very first thing I said, reduce spend. For example, they're looking at Medicare Advantage and saying, is it doing what I want it to do, which is to reduce costs, improve quality, thus holding feet to the fire, right? It's all part of one goal. It is not something that is a separate thing. What I am saying is that purchasers, in their frustration with us, perhaps their frustration that they're not seeing enough with value-based care, are saying, where can I turn the screws more, right? They're looking at our vulnerabilities. They're looking at all of those patient outcomes that are poorer and saying, where can we have more of a carrot, more of a stick to make sure that we're actually meeting our overall goals, which are, to our friend in the chat's point, the goals of value-based care. Now, what I've talked about thus far are all things that are happening right now, right? They are happening as we speak. We've talked about this moment of instability that we are in as an industry. We're talking about the purchasers that are trying to disrupt the legacy way of doing things because it's not working for anyone. It's not working for patient outcomes. It's not working for costs. It's not working for the federal government. It's not working for employers, right? Who is it working for? And so we're seeing more scrutiny across all purchaser segments. The dangerous position that health leaders are in is to merely react to all of those things. We are 34 minutes into this presentation. Have I said something positive yet? No wonder health leaders today are feeling antsy. They're feeling instability. And then they're in this moment of a very reactive approach to what is happening in healthcare. But that's a very dangerous position to be. We need to be making decisions now that will prepare us for the future, especially as, that instability and purchaser disruption aside, there are other tectonic plates that are changing underneath us in healthcare, right? I named some of them already. The delivery infrastructure that is moving away from hospitals and towards vertically integrated ecosystems. Care team roles are changing dramatically with technology. And treatment economics are going to have to change as the industry adapts to high and ultra high cost drugs. I'm not talking about $50,000 drugs. I'm talking about $3 million drugs, right? Those are massive paradigm shifts that we are going to need to prepare for. And it's the decisions that leaders make today that are going to impact the future. So what I'm saying is we can't get bogged down with all of the churn that I have talked about thus far. Now, of the paradigm shifts that I could talk about, and frankly, these are ones that advisory board has a lot of research and information on. They're ones that I talk about on the podcast all the time. The one that I really wanted to make sure I brought to this conversation is AI. That is in part because it's obviously a hot topic. It's one that this is the season where everyone is having their physician retreats. They're having their end of year retreats with their executive teams. There is not a single one of them that doesn't have AI on the agenda. I am positive of that. I'm also seeing a lot of misinformation around AI. I'm seeing a lot of fear around AI that I want to frankly get ahead of. So let's move to the kind of conversation that I want to have today. And again, the goal is that we're talking about the future. And the question that you should have for me is the future of what? So my goal as we talk about artificial intelligence is for me to help you predict if the first domino on artificial intelligence has already fallen, right? Cat's out of the bag, can't suspend gravity. Just when will the dominoes stop tipping? Or just when in your strategic lifetime as an executive in healthcare that is still making decisions, we know that we are moving away from the world that is on the left, right? That's the world of the past, the overextended generalist with maybe some automation at the margins. I know that is changing because of the massive accelerants of today, the workforce crisis, the dawn of generative AI, things that we're going to talk about. At the very least, we are going to get to a world where technology-enabled top-of-license care delivery is a non-negotiable. I'm going to say that again. At the very least, we are going to get to a world where tech-enabled top-of-license care delivery is a non-negotiable. But I do not think that that is the endpoint. It may be the future. It may be a future that we need to prepare for now, but it is not the final destination. So you'll notice in faded print for now, an even more extreme scenario that we're going to be talking about that might be our ultimate destination, or at least the destination for the next few years. I want to be clear that that is not something that is good or bad. It is something that is realistic. It is something that I need to name and for you to know in order to make better decisions about the future. Now, as I said, we're in this interesting moment where the accelerants underneath this force are just hitting the gas, right? We're in this interesting moment where the workforce problem and tech are both at tipping points. On the workforce side, we're not going back to the way things were before the pandemic, right? Look at the data on the left-hand side of the slide. While we made some improvements, that's a good thing, in things like turnover, vacancy rates compared to the last year, these metrics are still really bad. They're still higher than pre-pandemic levels. And some of the metrics are up from where they were last year, by the way, like RN time to fill, the cost of nurse turnover. No wonder then that labor is still the biggest challenge that I'm hearing from providers. Frankly, it's the biggest chief financial officer challenge that I'm hearing from health systems today. So that's a problem for providers. It's a problem for any of you who want to partner with providers. And I don't need to harp on these challenges, right? I'm sure that they feel very familiar to many of you who've been in healthcare for the last several years. The problem is that a lot of leaders still tell me they're just waiting for things to get better. They're just going to wait for things to go back to the way they were. I want to be clear, that is not going to happen. Bottom line, you cannot hire your way out of the labor problem. You cannot take the gas off of your recruitment and retention strategy. I want to be clear on that. But we are also going to need to find other strategies to make the most out of the workforce that we have, rather than trying to wait things out, rather than trying to hire our way out of a workforce crisis that continues, right? And as these workforce challenges continue, we're experiencing a moment where AI is exploding in popularity. Right? We have the advent of vast improvements in tech capabilities and increased staffing challenges, which means we are only going to see more organizations turn to tech to try to mitigate their staffing challenges. Now, if you are a provider, perhaps you are in care delivery yourself, or you work for a provider organization, when you're listening to this conversation, you're going, yeah, been there, done that. Even as I speak about what technology can do for clinicians, it is important to remember that a lot in the workforce don't see this as a solution, right? They see technology as part of the problem, and it's for good reason, because our previous massive technology investments weren't actually designed for clinicians. They certainly weren't designed to help clinicians. They were put in place for a different goal. And whether or not they're succeeding in that other goal is not part of this conversation. What did happen is there were unintended impacts on clinicians, and they were often negative. Right? Think about every complaint you get from a doctor about the EHR, about in-basket messaging, about the millions of apps. I have an app for every healthcare provider that I see. I have a folder on my phone filled with health apps just to check in, just to get on a portal. So moving forward, it is important to consider the impact that our tech investments will have on clinicians and have on our other priorities, right? Now, I was just talking about technology in kind of the broadest sense. That's a catch-all term. Today, we're talking about AI. I want to take a moment and make sure that we all understand what AI really means. I see it thrown around often, and I see it misused. Biggest thing that I want us to move away from is the myth that AI is magic, right? The idea that AI is just going to do exactly what I want it to do perfectly, that it's sentient, that it's essentially a human brain. That is not what artificial intelligence is. AI is also not a single technology, right? It's a whole field of technology that performs specific tasks, and it requires, today at least, human intelligence, right? Those technologies have to be trained. They have to be trained to do tasks effectively, and they improve over time. But they also, frankly, have limited utility outside of the thing that it has been trained to do. Now, what's new with generative AI is that these models have been trained on much bigger data sets, right? They just have more inputs to learn from, meaning they can generate new outputs, right? That's why the name generative AI. And they can adapt to new use cases with even less training, right? Generative AI models are not creating new outputs out of thin air. Again, not magic. In fact, one of my favorite ways to describe AI comes from one of my colleagues at Advisory Board, who says that AI is just the greatest plagiarist of all time, because it's just predicting the next word or the next image, right? And I hope that gives you a sense of what AI can and cannot do. That said, there are so many opportunities with AI and technology in healthcare. And I think we do it a disservice when we think about AI and frankly, any other tech as something new as of just the last few months, right? In reality, this has been brewing and being used and tested for a long time. We've already seen widespread use of AI in detection and screening, for imaging interpretation. We've seen it for visit documentation. And there are a lot of cases in this kind of emerging or exploratory phase where I'm not really talking about the future. I'm talking about the here and now. What I would say is that we are in the flip phone era of artificial intelligence. And if you were to tell me in 2004, that my flip phone was going to do what my iPhone does today, I would not have believed you. So while I am absolutely saying that we need to think beyond even this emerging and exploratory phase, no one, not me, not anyone else, can actually predict just how far AI will go in our world, in our business, and in patient care. Now, the question that I often get is, okay, great, there's so much opportunity. The world is our oyster. Well, then why aren't these things having a bigger impact? Why don't we see these use cases alone at every single organization? Allow me to bring us back to reality for a minute. This is a real screenshot. This is not a created image. This is a real screenshot from Docsimity's platform called DocsGPT. For those of you who don't know this platform, this is a platform that helps a lot of physicians sending messages to patients. And Doximity made a generative AI platform to help physicians with certain tasks. And I really actually like how they've organized it. They've shown specific use cases for how physicians can use it. So for example, at the top left, write a statement of support for Social Security disability for my patient who has bipolar disorder. This is a really good job of just demonstrating the different kinds of tasks where AI can help. I have a son, and I also really love the prompt on the bottom left. Write home care instructions for an 8-year-old with asthma, but do it in the style of Dr. Seuss. Cutesy example, but it really describes how artificial intelligence can allow us to provide more personalized care to patients. I often hear this fear of, this is just going to turn everything into cookbook medicine. But here we're describing something that really allows more personalized care for, in this case, an 8-year-old with asthma, right? We can meet different patients with different needs, who speak different languages, who have different levels of education, right? This can help even with some of our challenges like health equity. Another example that I like, physicians can use this to write an appeal when their patient is denied a certain medication. And so Doximity smartly thought, in my opinion, hey, we're doing all this work to draft the letter, although it takes a couple seconds to do, right? We're doing all this work to draft this letter. Let's help connect those physicians to the payer they need to send it to. What does that connection look like? You all know it. It's a fax. right? We have wonderful ambitions about this new technology at our fingertips. Some of it feels like science fiction, but the larger system is still handcuffed by the limitations of our reality, which in this case is a fax machine, right? I often think that people tend to talk about AI like it's something that's just going to solve all of our problems, right? That magical thinking. But at the end of the day, AI is a tool. It's a very sophisticated tool, but we have to think about it as a tool that will connect with all of our existing structures and frankly, all of our existing problems in healthcare. And every organization is going to face these constraints, right? Some more than others, though. Some organizations can invest in things like EHR upgrades. Some can't. If they can't invest in an EHR upgrade, are they going to be able to invest in the latest AI? No. So one thing that I am paying attention to is how organizations who have the resources and the tech foundation and the change management to actually invest early, how are they going to gain a competitive edge in operations, in efficiency, and in recruitment and retention of clinicians? Interesting question in the chat. Seemingly, would AI become more trusted if the data that it's tested and built on is longitudinal? Maybe. I want to be clear, and I'm going to repeat this again in a minute because it's worth repeating. And that is that these devices, these tools, these technologies designed by people have their own problems, particularly their own biases. One of my favorite data points, which let's see if I can get this right. In the 1950s, it used to take, I believe, 70 years for clinical knowledge to double. Want to know what it is now? It's days. It's days. And it is impossible for clinicians to keep up with all of the changes that are happening in science and technology and drugs and medicine, and things like artificial intelligence can help us do that, right? That's an example of better. A fun one I'll share with you from a couple of years ago of an organization that used an AI chatbot for like 300 easy kind of primary care diagnoses. They didn't want to do telehealth. They didn't want somebody to come to urgent care. They wanted to just get that patient a care plan, perhaps a prescription, as quickly as possible when they have a UTI, when they have a middle ear infection, things like that. And naturally, this was a couple of years ago, there were questions of quality and safety from the physicians. And so the medical group in this case that implemented this as a pilot ended up sharing reports with their physicians and shared that with the tech, their patients were less likely to be prescribed antibiotics that they did not need when they used the technology versus when it was a human being. Said another way, the human being could be broken down and said, oh God, it's a virus, but fine, I'll just give you the antibiotics, than when they had to go through the artificial intelligence chatbot, right? Question about, can I speak to the convergence of provider and payer organizations? That is a massive industry shift that we are watching right now. It is one of the 3 paradigm shifts that make up the backbone of this state of the industry work. I am not going to share it in this presentation because I want to focus on the paradigm shift of artificial intelligence, but I am going to share a QR code at the end. Go ahead and use that code if you want to, or use that QR code if you want to get more information on the provider and payer organizations coming together, those vertical ecosystems that have been growing. Absolutely a paradigm shift that we are watching in healthcare. How will the FDA play a role in regulating and perhaps slowing down the impact of AI? I think we're going to see in the next couple of weeks, right? There was just a hearing last week in terms of congressional oversight. So I think that is something to be seen in the near term. In the meantime, one of my takeaways for AI for all organizations is you need to get your own governance structure in order soon. And that's actually in part because one of the questions I hate getting the most is, Ray, what should my AI strategy be? I will not answer that question. I will not answer that question. I don't think that you should have an AI strategy. I think that you as a strategic organization should be looking at the problems that you have, the goals that you have, and then find the right solution to those problems. And that's when you start thinking about technology. That's when you start thinking about artificial intelligence. This slide has a great example of a couple of different goals and how you can look at what is the root cause challenge here. What is the primary reason, or what is the biggest reason why I'm not able to make progress on that goal? And then to think about your technology investment. And the reason why I really, really love it when organizations go through this process: what's the goal? What's the root cause challenge preventing my progress? What's the investment I need to make? And by the way, on the far right side, what are the tensions I'm going to hit in implementation? is because every single decision comes with trade-offs. Every single decision comes with trade-offs. But when you as a leadership team understand and have interrogated a problem and have prioritized a solution, you can hold that sacred. And the biggest reason why I bring this up is because of one of the number one fears that comes from clinicians is, sure, they want to make my life easier now so that I can just do more work later. You're going to take a bunch of work off of my plate just so I can see more patients. Well, think about where we started. If the primary challenge of today is the workforce crisis, we might need to not ask our physicians to see more patients. We've taken off of their plate so that they can do more top of license care. So we need to make sure that we're prioritizing top of license care, not more, not just more work, right? And there's a lot of different ways that we can do these goals, but I want to name 3 goals that should guide all of your technology decisions in this era of a heightened workforce crisis. First and foremost, interrogate the solutions you already have. Get the basics right first. Go back to the technology investments you've already made and think about, how do I make these better, more efficient? How can I use them already to extend clinician reach, which is often something that is a primary goal when I think about the workforce crisis. And lastly, a very, very important one, improve working conditions. My warning to you, you need to improve working conditions for all clinicians, not just physicians. Historical investments have all been geared towards doctors. There are a lot of reasons for that. One of the main ones is just healthcare's financial structure, right? It incentivizes physicians' productivity. It incentivizes a drive and a push for more visits because that increases revenue. However, nurses are often seen as a cost center. They're seen as something to be managed. So in the past, leaders have really struggled to prioritize nurses because, as the quote here says, nurses are largely invisible. However, think about the primary problem that we are talking about. Nurses are feeling the burden of especially bedside nurses, are feeling the burden of the workforce crisis more acutely than any other member of the clinical care team, more than any other member of the clinical care team. And they obviously play an incredibly important role in quality, safety, experience. All of the things that I said on the very first slide of this presentation are getting worse. It is beyond time to prioritize their workflows, right? Now, here's the bottom line. I don't think that robots are replacing doctors. I don't think that technology is going to replace humans. I'm going to stand by that, but it will change all of their roles. So what we need to think about is, how does the care team change along with it? How do I interrogate all of the roles on the care team? Who should do what tasks? What should do what tasks? Where does the learning happen? How will clinicians continue to gain necessary experience and expertise, whether that's in care delivery or in technology? When will schools, employers, accreditors actually standardize training here? Right? How will we value the work? How will compensation change in a world where human performance is blended with technology? Right? And above all, as you come to these individual questions that you will need to ask, that you see here on this slide, in order to answer any of them, you have to have a governing body to make those decisions proactively. You need a governance structure where there is a strategy of who and how you will respond when these questions come up, or any of the questions that you've thrown at me. What about compliance? What about what the FDA is going to do, right? What about congressional oversight, right? You need that governing body, and it will help you keep at the very center, not what should my AI strategy be, but how will AI solve problems? How will I use this body to interrogate all of the possible solutions or possible opportunities that I want to address, and figure out where technology plays into them? Now, this is a good way to start interrogating what top of license care actually looks like, which is a question that I just got in the chat. Now, when I often kind of imagine the care team, let me tell you how we used to imagine the care team. We used to imagine the care team like a pyramid or like a hill, right? And we thought about what is something that only the doctor can do, what is something that only the APP can do, what is something that only the nurse can do, et cetera, et cetera, et cetera. And if it wasn't one of those things, we knocked it down to the next level. There's a phrase with a curse word that describes the image that I'm painting for you right now. So instead of that, what we like to share is that your care team should look like a puzzle piece, right? Where every puzzle piece plays an essential role on the care team in terms of your goal. And again, top of license might look different depending on the goal of the physician office, the physician practice, the health system. If you're really focused on expanding access, because that is the number one problem that you have, first of all, you might have 3 medical assistants on your care team, right? Rather than just one, because one is rooming, one is taking the patient history, one is helping the physician, right? Because you've prioritized, you've been willing to make the trade-off that the number one thing that we need to focus on is patient access. Now, what I don't want you to walk away from this conversation and think is that, AI is just another puzzle piece. It is not. AI needs to be embedded into each of those puzzle pieces, into each of the ways that we develop those care team roles. Now, I have focused this conversation on AI's impact on the workforce, and that is because the workforce crisis drags on. It is still one of the number one challenges that I hear from health system CEOs and CFOs. It was not the case in 2019. Maybe it should have been, but it was not the case in 2019. But AI's impact is going to go beyond workforce, and I want to issue a word of caution. For as much as I believe and am excited by and am empowered by the future of artificial intelligence, we have to remind ourselves that this is a tool, right? As we move beyond this flip phone era, we are going to see AI's impact on a lot more, and that impact could be good, and it could perpetuate some of the industry's biggest challenges, the challenges that we've always had. Some things I'm worried about. Uneven progress. I mentioned this already. Uneven progress either among whole organizations or even among individuals. Is that going to increase the gap between the haves and the have-nots? What will that mean for health equity if a patient is in a region where no health system, no regional health plan has invested in generative AI? What will that mean for their care? I also want to remind you that technology investments, while they can absolutely improve things, they can also replicate things that don't already work well. And I'm particularly talking about the fact that humans operate with bias. Humans create these tools. Humans create these tools with bias, and that bias can continue. And so we have to make sure that we are not replicating that within the technology. And finally, keep an eye for who's gaining power and who's gaining control as AI becomes more prevalent in healthcare. Which vendors are you becoming more reliant on? Who controls and shapes the data that's feeding into the AI models, right? Something that's going to have an impact on bias. Which of these technology vendors are actually gaining more touch points with patients? Are patients listening to those touch points? Are the technology vendors now the ones who are nudging patients through their journey? Someone mentioned value-based care and the importance of that journey in managing costs and quality. Well, what if it's the tech vendors who are gaining power? Are they part of your value-based care strategy? Should they be? You have to be alert to these questions and these risks, because whether you believe it or not, AI is already in your organization. And that's true whether you have a platform that is approved or not. People in your organization are using ChatGPT today, right? Opting out of this is no longer an option. And I choose to believe that that is exciting. I, in particular, choose to believe that is exciting because I have spent my 10 years at advisory board speaking to different kinds of health leaders and spending a lot of time with physicians. And just a short time ago, physicians were pretty afraid of AI. They said, yeah, it's going to happen, but not now. We're not ready. Those aren't the conversations I have anymore. The conversations I have are all excited. They're excited to use technology and artificial intelligence in their workflow. I said that I didn't think tech-enabled top-of-license care was the end. What could be the end is that clinicians are actually the complements to technology, not the other way around. Now, again, technology is not going to replace humans. I stand by that. But if I think about the degrees of change that are possible, I imagine us driving towards a future where clinicians are the complements to technology rather than the other way around. Frankly, we have already seen examples of that. So in this moment of extreme tech innovation, extreme tech implementation, we have to concern ourselves with how we're not just going to embrace new opportunities, but think very, very purposefully about what it means for care team roles. This new era of tech enablement will open the door for greater efficiency. It can also entrench inequities if we're not careful, and it will shift control over care decisions. What I am saying is this paradigm shift will reshape healthcare. It will reshape healthcare and outcomes, and frankly, who has the power over the patient relationship. Now, I mentioned that this is one part of 3 different paradigm shifts we could talk through. So in a moment, I'm going to show you a QR code to get access to this presentation. I'm going to leave this slide for your review. I always like to leave with an actionable item. This actually breaks down what every major stakeholder should do as a result of the major paradigm shifts, only one of which we talked about today, which is artificial intelligence. I also want to let you know that Advisory Board is a proud sponsor of Health 2023. We are going to be in Vegas in October, so please join us for 3 table talks where we are going to be digging into some of the conversation we had today, particularly and some of the things we did not, particularly in the drug space. We'll talk about what it means for providers, for life sciences companies, for tech. So visit the Health 2023 agenda to find the Advisory Board table talk times and presentation details. I would love for you to subscribe to Radio Advisory wherever you get your podcasts. You can hear my voice in your earbuds every Tuesday as I talk through some of the challenges like we talked through today. And the moment you've been waiting for, please use this QR code to get access to these slides and to ask more questions about how Advisory Board, how this research can support your goals, particularly some of the burning questions that you all have on some of the other major paradigm shifts in healthcare. Thank you all so much for your time. This was great.
Thank you to Rachel and to everyone that joined us today. Please visit our website at community.hlth.com to catch up on all Health Go Live webinars. And join us in Las Vegas, October 8th through 11th for Health 2023.